Firstly, with the convex transducer, which is the transducer specifically for abdominal use, and which allows me to explore through the intercostal spaces, through the epigastric region, and then continuing through the whole abdomen. After doing a clinical examination, I looked a little bit on the biology of the patient, because a lot of them also have the biology handy. The next step is the application of the gel, and then comes the selection of the transducer, which is a convex transducer. In this case, as I said, which I choose, I go here and choose from it. You see, the moment I choose from the icon that the keyboard gives me, I choose my transducer, the automatic machine starts working and gives me the image in the section that is set by the company. In this case, I have an inverted image, because you can see how the patient's right lobe is on my right. We, by convention, always use the inverted image. Either I use the key on the display and have it reversed electronically, or I flip the transducer. Right, at this point we're on the conventional image, so to speak. In most subjects we get the liver image with the left lobe of the liver, the falciform ligament, and that continues with the ligamentum venosum of Aurantius, the right lobe aspect, and the left lobe aspect on this section having a somewhat triangular image. That is, the ratio of the right lobe to the left lobe is somewhat 2:1. It's an image that I see at a glance. So right off the bat, I can tell that this is not a large liver. Obviously, I check my image, and you should know that in ultrasound, we usually always check for some suspicion on the image. For example, if I said before that the liver here is dimensionally normal, then I automatically put the transducer through to draw a lot of air into the chest, into the right hypochondrium. I ask the patient to draw a lot of air into the chest, and in the area where I see approximately and the right lymph node breathe, I make an indicative measurement between where I suspect the diaphragm would be here and the lower edge of the liver, and in principle a normal liver should be below 15 centimeters. It may be plus or minus something, but basically we are also dealing with a normal liver here. After that it pulls, yeah, sure, cranially caudal. Now why do I point out the orientational thing? Because the machine measures perfectly, so the distances that the equipment measures are non-negotiable, they are correct, but our hand never puts the measuring device in the same place. So we have an approximate measurement that we have to take into account, but obviously we have other landmarks to say whether we are dealing with organomegaly or not.